Hello everyone, today in dermatology lectures we are going to discuss the structure of the skin, the function of the skin, inflammation of the skin, and primary and secondary skin lesions. Next slide. The skin, along with our hair and nails, is part of the integumentary system of the human body. It basically covers our body. The skin is the largest organ of the human body by mass, as well as by size. Please, we will see a short video about skin cell renewal or division. This lecture, we're going to focus on the structure of the skin, the function of the skin. The skin consists of 3 different sections and it consists of different types of tissues: the connective tissue, epithelial tissue, and muscle, fat tissue, and nervous tissue, and these 5 different types of tissue work together to carry out a specific set of functions. Next slide. We can divide the skin into 3 different regions. The outermost section of the skin is known as the epidermis. The middle portion is known as the dermis, and the lowest portion is known as the hypodermis, or the subcutaneous layer. Please watch the second short video.
The skin covers the body and protects it from the external environment. It also prevents water loss, provides sensory function, plays a role in body temperature regulation, and is the site of vitamin D synthesis. The skin is composed of 2 layers, the outer epidermis and the deeper dermis. The dermis is connected to underlying structures via a subcutaneous tissue, the hypodermis, which is not technically considered part of the skin. The epidermis provides barrier and protection. It consists mainly of the protein keratin, a tough and water-insoluble structural protein. The dermis constitutes the bulk of the skin. It provides support and flexibility. The dermis consists mainly of collagen and, to a lesser extent, elastin fibers. Loss of collagen and elastin, such as with aging, causes the skin to slack. The boundary surface between the epidermis and dermis is not flat but wavy, meaning the 2 tissues interlock, strengthening their connection. With age, this boundary flattens and the skin becomes more fragile. The dermis is well vascularized and contains sensory nerves, hair follicles, sebaceous glands, and sweat glands. It has 2 zones, the upper papillary dermis with loose connective tissue and the lower reticular dermis with denser connective tissue. The dermis houses immune cells and allows inflammatory response to activate upon exposure to invading organisms. The hypodermis is composed of loose connective and adipose tissues. This is where most of the body fat is stored. The hypodermis provides thermal insulation, padding, and serves as the body's main energy storage. The thickness and proportion of the epidermis and dermis vary greatly depending on their location on the body, but the skin is classified as thick or thin based on the thickness of the epidermis alone. Thick skin is found only in areas where there is a lot of abrasion, palms, soles, digits, and has 5 epidermal layers. Thin skin is everywhere else and has 4 epidermal layers. Most cells of the epidermis are keratin-producing cells, or keratinocytes. New cells are constantly produced by mitotic cell division in the basal layer. They then move toward the skin surface as they age and differentiate, changing shape from cuboidal to flat. The distinct epidermal layers represent different stages of keratinocyte differentiation, from their birth to their death. The spinous layer is characterized by presence of abundant desmosomes which connect keratin filaments of adjacent cells, anchoring them together, providing resistance to physical stress. The granular layer is loaded with keratohyalin granules. These granules release several substances that cross-link keratin filaments, converting them into an impermeable keratin matrix. This process is known as cornification or keratinization, the result of which is the most superficial layer, the cornified layer, about 30 cells thick. These fully keratinized dead cells form the skin barrier. They are shed periodically from the surface as new cells are moving up. The entire epidermis is replaced every 30 to 40 days. The renewal process becomes slower with age, but faster in injured skin, when cell proliferation is accelerated for wound healing. The epidermis also contains immune cells, touch sensory cells, and melanocytes. Melanocytes produce the pigment melanin and transfer it to the keratinocytes. The amount of melanin produced is the major determinant of skin color. Melanin synthesis is stimulated by UV light and is thought to be a protective mechanism against UV radiation damage.
Now we will discuss all of these, one by one in detail. The outermost portion of the skin, the epidermis, actually consists of 4 different types of cells. 1. The skin is made up of 2 parts, cutaneous membrane. Epidermis epi, above, composed of stratified squamous epithelium. Dermis, papillary layer, areolar connective tissue. Reticular layer, dense irregular connective tissue. 2. Accessory structures, hairs, nails, exocrine glands, sebaceous glands, sweat glands, sensory receptors and nerve fibers, erector pili muscles. Next slide. What is human skin? Human skin is approximately 3 millimeters thick, 1.5 to 2 meters in area, 16% of body weight. Skin is the integument of human body, is the largest and most heterogeneous organ of the body. It is composed of tissue that grows, differentiates, and renews itself constantly. Skin has a multifunctional role, which includes a protective barrier against the ingress of foreign material, chemicals including drugs, microbes and radiation, and the loss of endogenous material, such as water, regulating body temperature, and also acts as an immunological and sensory organ. Next slide. Epidermis as a stratified squamous epithelium, very thin layer and is firmly attached to the dermis at the dermipodermal junction. The epidermis is composed of 4 or 5 layers, depending on the region of skin being considered. Thin skin covers most of the body, has 4 layers of keratinocytes. Thick skin covers the palms of the hands and soles of the feet, has 5 layers of keratinocytes. Next slide. The epidermis is the most superficial layer of the skin. It is very important from a cosmetic standpoint. This layer gives the skin its texture and moisture, and contributes to skin color. If the surface of the epidermis is dry or rough, the skin appears aged. The epidermis primarily consists of keratinocytes, proliferating basal and differentiated suprabasal, which comprise 90% keratinocyte cells, but also contains melanocytes, Langerhans cells, and Merkel cells. Next slide. Keratinocyte gradually migrates to the surface and is sloughed off in a process called desquamation. When the stem cells divide, they create daughter cells, which slowly migrate to the top of the epidermis. This process of daughter cells maturing and moving to the top is called keratinization. Next slide. As keratinocytes migrate through the layers of the epidermis, their contents and functions change according to, or depending on, the specific epidermal layer in which they are moving. The layers of the epidermis are named for these characteristic traits. For example, the first layer is the basal layer because it is located at the base of the epidermis. Next slide. The next layer is referred to as the spinous layer because the cells in this layer have prominent, spiny attachments called desmosomes. The next layer is the granular layer, named so because these cells contain visible keratohyalin granules. The last, outermost layer is the stratum corneum, a condensed mass of cells that have lost their nuclei and granules, dead cells also known as corneocytes. Next slide. Epidermal layers from deep to superficial. The stratum basale is a single layer. The basal layer just above the basement membrane contains keratinocytes. Basal cells join with the basement membrane by hemidesmosomes, and the overlying spinous cells by desmosomes, melanocytes, Merkel cells, and Langerhans cells, latter mainly in stratum spinosum. Basal cells are responsible for maintaining the epidermis by continually renewing the cell population. Next slide. 10% of cells in the basal layer are stem cells. Normally, stem cells are slowly dividing cells, but under certain conditions such as wound, healing, or exposure to growth factors, they divide faster. In normal skin, the migration of the keratinocytes from the basal to the skin surface takes between 24 to 30 days, during which time the cells synthesize lipid structures and proteinaceous materials called keratin. Next slide. So let's take a look at the following diagrams. Lowest portion is the stratum basal. Within the stratum basal we have the Merkel cells shown here. We also have these green cells or melanocytes. Specialized cells of stratum basale. Merkel's cells that respond to touch trigger the nervous system. Melanocytes contain the pigment melanin. Melanin also absorbs harmful UV rays and protects against cellular damage from UV light exposure. Next slide. Stratum spinosum, the spiny layer. Produced by division of stratum basal. 8 to 10 layers of keratinocytes bound by desmosomes. Cells shrink until cytoskeletons stick out, spiny. Continue to divide, increasing the thickness of the epithelium. Contain dendritic, Langerhans cells active in an immune response. Next slide. Stratum spinosum, the spiny layer. Desmosomes are very prominent in this layer, thus accounting for the name spinous layer. Lamellar granules, which are considered the first sign of keratinization, first appear in this layer. They contain lipids such as ceramides, cholesterol, and fatty acids as well as enzymes such as proteases, acid phosphatase, lipases, and glycosidases. Next slide. Lamellar bodies known as keratinosomes or Odland bodies are secretory organelles derived from the Golgi apparatus of keratinocytes in the upper part of stratum spinosum. From the site of production, lamellar bodies migrate to the top of the stratum granulosum, and then into the intercellular domain of the stratum corneum to extrude their contents, which are predominantly lipids. The lipids ultimately form the lamellar lipid bilayer that surrounds corneocytes and also contribute to permeability barrier homeostasis of the stratum corneum. Next slide. This perturbation induces lamellar bodies to undergo exocytosis and secrete lipids, such as ceramides 30 to 50% by mass, cholesterol 25% by mass, and free fatty acids 10 to 20% by mass, mostly produced by lamellar bodies. These hydrophobic components fuse together to form multiple bilayers of lipids between corneocytes to act as the principal barrier to the transcutaneous movement of water and electrolytes. The cytoplasm contains proteins not found in the lower layers, such as involucrin, keratolynin, and loricrin. These proteins become cross-linked in the stratum corneum to confer strength to the layer. Next slide. Next slide. The granular layer. Keratinocytes reside in the uppermost viable layer of the epidermis. The granules represent keratohyalin granules, which contain profilagrin, the precursor to filagrin. The protein filagrin cross-links keratin filaments, providing strength and structure. When filagrin is degraded, urea, pyrrolidine carboxylic acid, glutamic acid, and other amino acids are produced. These are collectively referred to as the natural moisturizing factor of the skin, NMF. Natural moisturizing factor absorb water from the atmosphere to ensure that the superficial layers of the stratum corneum stay hydrated. As they are water-soluble themselves, excessive water contact may leach them and inhibit their normal functions, which is why prolonged contact with water makes the skin drier. Natural moisturizing factor, sponge-like substances in the cells. The stratum corneum is the outermost of those 5 layers and largely acts as a barrier. The stratum corneum contains about 16 to 30 layers of corneocytes. The stratum corneum is described as the dead layer of cells because these cells do not exhibit protein synthesis and are unresponsive to cellular signaling. Understanding the structure and function of the stratum corneum is vital because it is the key to having skin that is healthy and attractive. Next slide. Next slide. Derm is made up of 2 layers comprising of fibrous proteins, collagen and elastin, which give skin its strength and elasticity. Next slide. The structures and functions of the dermis. The dermis lies between the epidermis and the subcutaneous fat. The dermis is the thick, elastic but firm middle layer of the skin made up of 2 sub-layers. The uppermost portion of the dermis, which lies beneath the epidermis, is known as the papillary dermis, and the lower portion is known as the reticular dermis. The upper layer, or stratum papillary, forms a defined, wave-like border with the epidermis. The lower layer, or stratum reticular, a deep, thick area, which forms a fluid border with the subcutis. Next slide. The dermis consists of a matrix of loose connective tissue composed of fibrous proteins, collagen and elastin, embedded in an amorphous ground substance, gel-like substance. The ground substance consists primarily of water ions and complex carbohydrates such as glycosaminoglycans and hyaluronic acid, which have a high capacity for water binding and help to maintain the volume of our skin. Next slide. Collagen, one of the strongest natural proteins and the most abundant one in humans as well as in skin, imparts durability and resilience to the skin. Elastic fibers represent one of the essential components of the glycation of the extracellular matrix of connective tissue. They confer resilience and elasticity to the skin. As we age, our natural production of collagen and elastin slows down, and the skin's ability to bind to water decreases. Skin looks less toned and wrinkles appear. Fibroblasts are the primary cell type in the dermis. They produce collagen, elastin, other matrix proteins, and enzymes such as collagenase and stromatolin. Immune cells such as mast cells, polymorphonuclear leukocytes, lymphocytes, and macrophages are also present in the dermis. Next slide. The dermis plays a key role in protecting the body from external influences and irritants, as well as feeding the outermost layers of skin from within. Its thick, firm texture helps to cushion external blows, and, when damage occurs, it contains connective tissues, such as fibroblasts and mast cells that heal wounds. It is rich in blood vessels that nourish the epidermis while removing waste. The sebaceous glands, which deliver sebum to the surface of the skin, and the sweat glands, which deliver water and lactic acid to the surface of the skin, are both located in the dermis. These fluids combine together to make up the hydrolipid film. The dermis is also home to lymph vessels, sensory receptors, hair roots, the bulbous end of the hair shaft where hair is developed. Next slide. Sensory receptors in the epidermis, free nerve endings. Sensitive to touch and pressure, tactile corpuscles. Detect texture and steady pressure. Next slide. Sensory receptors in the dermis. Meissner corpuscles. Detect light touch, pressure, and vibration. Pacinian corpuscles. Detect deep pressure and vibration. Ruffini corpuscles. Sensitive to pressure and stretching of skin. Next slide. Sebaceous gland. On the palms, soles, and dorsa of the feet. They are part of the pilosebaceous unit, and their secretion, sebum, flows through the sebaceous duct into the follicular canal. Sebaceous glands are larger and dense on the face and scalp as compared to other areas of the body. Sebaceous gland secretion is holocrine in nature, and it is a continuous process. Next slide. Their growth is under endocrinologic control, and the major stimulus affecting sebaceous gland growth and sebum secretion are androgens. In males, testosterone and its metabolic products, like dihydrotestosterone, provide the major stimulus. In females, sebaceous gland growth and sebum secretion are under the control of ovarian and adrenal androgens. Sebaceous gland growth is one of the earliest signs of puberty. Next slide. Sweat glands. There are two types of sweat glands, eccrine and apocrine. Eccrine glands are found in large numbers only in men and some primates. They are distributed over the entire skin surface. Their secretory portion is a coiled tubular structure located deep in the dermis. From this portion, the ductal portion arises. The duct ascends straight through the dermis, assumes a spiral configuration in the epidermis, the acroceryngium, and opens onto the skin surface. Next slide. Eccrine glands are innervated by sympathetic cholinergic fiber. The function of the eccrine glands is to respond to thermal stress by delivering hypotonic sweat to the skin surface, where it evaporates, cooling the skin, and thereby reducing the core body temperature. Thermal sweating occurs over most of the skin surface. Emotional stress can induce eccrine sweating in selected areas like the palms, soles, axilla, and forehead by a mechanism that is not well understood. Next slide. Apocrine glands are found in many mammals. In men, they are localized mainly to the axillary, areolar, and genital regions. Modified apocrine glands are found in the breast and the external auditory canal. Apocrine glands have a coiled secretory portion deep in the dermis. However, the duct leading from the apocrine gland, rather than opening directly onto the skin surface, it opens into the hair follicle above the entrance of the sebaceous duct. Myoepithelial cells surrounding the gland help to force the secretions outward. Apocrine glands produce an odorless, oily fluid which acquires a scent only after it interacts with skin surface bacteria, diphtheroids. The gland is largely under hormonal influences, but its duct is innervated by sympathetic adrenergic neurons. Apocrine glands are androgen-responsive structures that become active at puberty. They contain large quantities of 5-alpha reductase. Next slide. Skin function. A sensation, the largest sensory organ in the body, B. Protection. 1. Prevents dehydration. 2. Prevents infection. 3. Physical barrier to injury. 4. Protects against ultraviolet light injury, melanin. C. Thermoregulation. 1. Insulation, hair and adipose tissue. 2. Heat dissipation. A. Sweat evaporation. B. Increased blood flow. D. Metabolic. 1. Energy storage of triglycerides in adipose tissue. 2. Vitamin D synthesis. Next slide. Functions of the skin. A sensation functions of the skin, the largest sensory organ in the body. Sensory perception allows you to feel pain, pressure, heat. This helps us to identify potential dangers and avoid injury. Sensory receptors in the dermis include Meissner corpuscles detect light, touch, pressure, and vibration. Pacinian corpuscles detect deep pressure and vibration. Ruffini corpuscles sensitive to pressure and stretching of the skin. B. Protection functions of the skin include 1. Prevents dehydration. Horny layer functions as a protective barrier. One of its protective functions is to prevent transepidermal water loss. Cells of the mid-cornified layer have the most amino acid content and therefore have the highest capability for binding to water. Amino acids and their metabolites are produced during keratinocyte cornification, pyrrolidin carboxylic, sweat, and secretion by sebum glands, including urea, salts, and organic acids, and comprise a substance known as the natural moisturizing factor. And lipids released by the lamellar granules, located extracellularly, play an important role in skin hydration. Next slide. 2. Prevents infection. Skin is also part of the innate immunity, natural resistance of the body against invasion by microorganisms. The dryness and constant desquamation of the skin, the fatty acids of sebum, and the lactic acid of sweat all represent natural defense mechanisms against invasion by microorganisms. Langerhans cells and the normal flora of the skin that is resident on our skin. Bacterial species are by far the most numerous. However, fungi, viruses, and mites are also found on the skin of normal healthy humans. Microorganisms are found all over the skin surface. A resident flora is an important defense mechanism against pathogenic organisms because they compete with pathogenic organisms for nutrients. C. Produce antibiotics and other chemicals which inhibit the growth of pathogens called bacteriocins. D. They enhance the immune response to pathogenic bacteria via interferon, other cytokines, and phagocytosis. E. Lipoticoic acid in the cell wall of gram-positive bacteria stimulates mast cells to release cathelicidin, an antimicrobial peptide. Next slide. 3. Skin function physical barrier to injury. 4. Protects against ultraviolet light injury. Melanin. Melanin pigment of the skin protects the nuclear structures against damage from ultraviolet radiation. C. Thermoregulation blood vessels constricts or dilate to raise or lower body temperature. Sweat production promotes cooling. 1. Insulation, hair and adipose tissue. 2. Heat dissipation. Sweat evaporation. Increased blood flow. D. Metabolic. 1. Energy storage of triglycerides in adipose tissue. 2. Vitamin D synthesis metabolism photochemical reaction in the skin produces vitamin D essential for the metabolism of calcium. Please let's go and watch video about the protective function of the skin and thermoregulation.
The skin is the main organ involved in the regulation of body temperature. Now let's see how the skin changes to keep the body temperature stable under cold and hot conditions. Under cold conditions, different structures in the skin make responses to reduce heat loss from the body. Firstly, erector muscles in the skin contract to pull hairs upright. This traps a thick layer of still air close to the skin surface. Since air is a good insulator, the heat loss to the surroundings is reduced. Secondly, sweating is reduced. This helps reduce heat loss from the body due to evaporation. Thirdly, the arterioles in the skin constrict so that less blood flows to the capillaries near the skin surface. As a result, less heat is lost from the skin to the surroundings by conduction, convection, and radiation. Fourthly, the layer of subcutaneous fat becomes thicker. This better insulates the body. This is a long-term response to a cold environment because the subcutaneous fat takes time to develop. Under hot conditions, the skin makes responses to promote heat loss from the body. Firstly, erector muscles in the skin relax so that hairs lie flat. This traps a thin layer of still air close to the skin surface. As a result, heat is lost more quickly from the body to the surroundings. Secondly, sweating is increased. The evaporation of more sweat from the skin absorbs more heat from the body's surface so that more heat is lost to the surroundings. Thirdly, the arterioles in the skin dilate so that more blood flows to the capillaries near the skin surface. As a result, more heat is lost from the skin to the surroundings. Fourthly, the layer of subcutaneous fat becomes thinner. Therefore, the insulating effect is reduced. This is a long-term response to a hot environment.
Life on Earth would not be possible without a barrier that preserves us from dehydration. This is the reason why the skin barrier plays an essential role in the life of human beings. The top layer of the skin, called the epidermis, forms the epidermal barrier and serves as the body's first line of defense against external agents. Corneal cells on the surface are stacked like a brick-and-mortar wall, with three essential epidermal lipids: ceramides, cholesterol, and free fatty acids, forming the mortar between the cells. All of the cells that make up the epidermis begin their differentiation journey in the basal layer as germinal cells, called keratinocytes. As each differentiates, it migrates upwards to the spinosal layer, anchoring via desmosomes, then up to the granulosal layer, where they are anchored by special protein structures called tight junctions. Here they produce oddland bodies, vesicles containing the precursors of the three epidermal lipids. As the vesicles release their precursors, these move upward towards the outer layer, undergoing chemical modifications to become a solid three-dimensional structure. This is the mortar that not only keeps invaders from penetrating the skin, but keeps water from evaporating too quickly. The ratio of these lipid components is key. Without the ratio, permeability and barrier breakdown will occur.
Other functions of the skin include excretion, transmits small amounts of water and body waste via sweat, helps to prevent dehydration. F. Absorption. Some substances can be absorbed directly into the bloodstream. G. Fingerprints. The characteristic elevated ridge patterns on the fingertips of humans are unique to each individual. The medico-legal importance of the ridge patterns of fingerprints. Now we will talk about the second part of the lecture. Today in dermatology lectures, we are going to discuss inflammation of the skin and primary and secondary skin lesions. What can be understood by the words primary and secondary elements or skin lesion or rashes? By primary and secondary morphological elements, the dermatologist can determine the course of the pathological process in the skin and can also determine the preliminary diagnosis of skin diseases. Therefore, they are of great importance in dermatological practice. A skin lesion is a broad term that refers to any abnormality on the skin. It can be a rash, molewart, cyst, blister, discoloration, or another change on the skin surface. They usually result from skin inflammation, which can have many causes. Inflammation is a localized physical condition in which part of the body becomes reddened, swollen, hot, and often painful, especially as a reaction to injury or infection. Symptoms of acute inflammation last a few days. Subacute inflammation lasts 2 to 6 weeks. Chronic inflammation can continue for months or years. There are 3 types of inflammation. Exudation, vascular changes, outflow of liquid substance. Corpuscles. From the vessels. Proliferation and increase in the number of cells and intracellular. Structures by mitosis, karyokinesis, or amidosis and cell differentiation. Alteration, signs of tissue destruction. Next slide. Next slide. Exudation. This inflammatory response leads to blood vessel dilatation and increased permeability, resulting in increased production of exudate. The nature and quantity of exudate depend on the nature and severity of the tissue damage. Pathological processes which belong to exudation. Vacuole degeneration, spongiosis, and ballooning degeneration. Next slide. Next slide. Vacuolar degeneration is a pathologic change that can occur in cells of different tissues. Is intracellular edema, parenchymatous degeneration of cells characterized by the appearance in the protoplasm of vacuoles located close to or around the nucleus, and pushing off the nucleus towards the periphery. Vacuolar degeneration is seen in lichenoid reactions like cutaneous lupus erythematosus, dermatomyositis, and drug reaction. Spongiosis, intercellular edema of the epidermis. Exudation separates some epithelial cells and stretches intercellular bridges, which results in a complete loss of intercellular communication and formation of the epithelial vesicles. Next slide. Ballooning degeneration, a combination of intra- and intercellular edema. In addition to the changes within the epithelial cell proper, intercellular bridges are destroyed, which result in the formation of multiple cavernous vesicles with septa inside. Proliferation, an increase in the number of cells and intracellular structures by mitosis, karyokinesis, or amidosis and cell differentiation. Exudative pathological processes which belong to proliferation. Hyperkeratosis, thickening of the corneal layer. Parakeratosis, deficient keratinization, presence of nuclei in the cells of the corneal layer, absence of the granular layer. Acanthosis, thickening of the prickle cell layer. Granulosis, thickening of the granular layer. Hyaline degeneration of cells, the appearance of the glassy, semi-transparent substance of dense consistency, hyaline. Next slide. Next slide. Next slide. Next slide. Next slide. Alteration is the manifestation of tissue damage, dystrophy and necrosis of the tissue elements. Acantholysis degeneration and atrophy of intercellular epithelial bridges, weakening and complete disruption of intercellular cell-to-cell contact take place in the prickle cell layer of the epidermis. It leads to the formation of intraepidermal vesicles. Nucleus reaction is the degeneration in the cells of the epidermis, manifested in the swelling of their nucleus associated with infection by viruses or other agents of toxic origin. Before you can make a diagnosis of any skin lesion, it's important to be able to accurately describe the skin lesion. What are the most important facts to know about skin lesions? So please everyone, let's watch this video. It will help you understand how we do skin examination. Next.
So in this video, we're going to talk about ways to describe skin lesions. Let's begin with a macule. A macule is described as a flat, circumscribed alteration in skin color. An example of a macule is a freckle. A papule is a circumscribed, palpable elevation, less than 5 millimeters in diameter. An example of this is a mole. The one up from a papule is known as a nodule. A nodule is a circumscribed, palpable elevation greater than 5 millimeters in diameter. An example of a nodule is a wart. If the lesion contains fluid, this can be referred to as a vesicle, as long as it is a small collection of fluid below the dermis, and it's less than 5 millimeters in diameter. An example of this is a blister caused by the human simplex virus. If the fluid is greater, if the blister you can say is greater than 5 millimeters, it can be referred to as a bulla. A bulla is a large collection of fluid below the epidermis, greater than 5 millimeters. An example of this is a burn blister. Remember that a vesicle and a bulla are a collection of fluid below the epidermis. A pustule is pus. Pustule is a visible collection of pus. And a pustule can be an acne, for example. A lesion can also contain fluid within the dermis layer, not the epidermis, but the dermis, and this is known as a wheal. So a wheal is an area of dermal edema. An example of this, a wheal condition, is known as hives, which is an allergic reaction. A plaque is a palpable raised flat disc-shaped lesion. and it's often solid. An example of a plaque lesion can be seen in psoriasis. If the skin lesion looks crusty, we can use the term crust. A crust is defined as dried serum and exudate. An example of crust lesion is we can see in impetigo residues. Scales can also be used. Scales is defined as an accumulation of excess keratin. This can be seen in dandruff. Dandruff is an example of scales. Finally, a term that we should be all familiar with is ulcer. And ulcers can be found in the skin, in the gut, because these ulcers occur on epithelial cells. An ulcer is described as a circumscribed loss of tissue. An example is a pressure ulcer. So those are some terminologies or terms used to describe lesions. Again, macule, papule, nodule, pustule, wheal, plaque, crust, scale, and ulcer. So that was it for this video, terms used to describe skin lesions. Next, we will look at some common skin disorders and hopefully incorporate some of these terms to describe the common skin disorders. Thanks for watching.
Hi, I'm Dr. Justin Coe. I'm Clinic Chief of Medical Dermatology at Stanford Medicine. Today we'll be talking about a general approach to the dermatologic examination. To describe skin lesions, first we have to learn the language of dermatology. It's the common language that we share to describe skin lesions, and this is something we call morphology, which is to describe the general appearance of a skin lesion without any regard to its pathogenesis or its underlying etiology. The first thing that we have to do is we have to identify the primary lesion. We're going to go through and talk about the different primary lesions and provide some clinical examples and images of each. A macule is a non-palpable, less than 1 centimeter lesion, and a petechiae is an example of a macule. If we were to take a macule and increase its size to greater than 1 centimeter, we would have a patch. Vitiligo is a perfect example of a patch. A raised patch, something that you could feel that's raised above the surface of the skin, is called a plaque. Psoriasis is a great example of a plaque. If you were to take a macule and make it palpable, still less than 1 centimeter, we have a papule. And a papule is something that we see typified by a cherry angioma or a wart. In addition, you can have a large papule, something greater than 2 centimeters, which is dome-shaped, and you call that a nodule. An epidermal inclusion cyst is a commonly encountered nodule that we see in the skin. A vesicle is a clear fluid-filled lesion. Herpes is an example of a vesicle. If we have something that looks like a vesicle, but that's instead filled with pus or purulent material, we call that a pustule. And we see pustules in acne and certain kinds of drug eruptions. A large vesicle, greater than 1 centimeter, is called a bulla. And we see bulla in friction or in blistering conditions like bullous pemphigoid. So after we choose the appropriate noun, we have to fill it out with some adjectives. We can talk about the size of a lesion. We can talk about whether or not its borders are clearly defined, in other words, its demarcation. Well-demarcated lesions such as we see in erysipelas. Alternatively, lesions can be not well demarcated, such as in cellulitis. We can also talk about its color, and in dermatology there's a lot of conditions which have characteristic colors to them. One example is we see the white of vitiligo, a loss of pigmentation. We can also see a bright red of a drug eruption or a viral exanthem. In addition, purple sometimes connotes a vascular process like Kaposi's sarcoma. We can also see things in the skin that are granulomatous appear brown in color. Yellow sometimes makes us think of xanthomatous lesions or fatty lesions. In addition, we can sometimes see black as being necrotic skin or an eschar. We also see blue as a deep pigmentation, for example, in something called a blue nevus. In addition to the primary morphologies, we oftentimes have secondary or overlying morphologies. Some of these examples include serum, which is dried crust. We can see this in impetigo, or we can see this in acute or subacute eczema. Fissuring is something that we can see, which is a splitting of the skin as a result of hand or foot psoriasis. We can also see lichenification. Lichenification is the thickening of the skin and accentuation of skin lines as a result of chronic rubbing or scratching. Erosions are partial loss of the epidermis, and sometimes we see this as a result of scratching or injuring the skin. Ulcerations are full thickness loss of the epidermis, and sometimes these are frictionally derived or as a result of other primary processes.
It's important to consider the distribution of skin lesions throughout the body as they can help you with the diagnosis. For example, lesions on the extensor surfaces of arms and legs can be seen in psoriasis. Generalized distributions occur in certain drug reactions. We could see a photodistributed rash in connective tissue diseases such as lupus or dermatomyositis. That was a lot of information, so let's quickly review the important parts. Whenever you are attempting to describe a skin problem, remember the primary lesion morphology, size, demarcation, color, secondary morphology, and distribution.
What you'll need for a skin examination is a well-lit room, a ruler, a magnifying glass, a handheld source of light, and an open and curious mind. So we have a patient here today who's going to help us go through some of the important considerations for a dermatologic examination. Hello, sir. Thanks for coming in.
Thank you, doctor.
So using some of what we just discussed, let's practice by describing our patient's rash. So the first thing we want to do is we want to carefully choose our primary lesion. I'm going to choose this area here. When I touch it, I feel that it's raised above the surface of the skin. It's larger than 1 centimeter in size, so the appropriate primary lesion term would be a plaque. After we choose our noun, we want to think about some other descriptive terms that help us fill out some of the adjectives. This is probably a few centimeters in size.
Well demarcated.
Its color is probably dully red, I would describe it as.
In regards to secondary morphology, we see
that it has some crusting, which is dried serum or dried blood. We can also see superficial erosions or areas that the skin has been disrupted. And also we notice some subtle scaling. So taken all together, this is consistent with a diagnosis of psoriasis. This erythematous plaque with overlying scale, excoriation, serum crust, and different lesions and stages of evolution are consistent with this diagnosis on extensor surfaces of the body. One of the other things that we can do sometimes is perform special tests. Sometimes what we do with scaly lesions like this is if we were to peel off some of the scale, we can see if we see an Auspitz sign, which is signs of focal bleeding from blood vessels that are high up in the surface of the skin. The other thing that we notice about this, stepping back from the primary lesion, is the distribution of the lesion. And looking at the legs, it tends to be on the extensor surfaces of the body. So we see that these plaques are distributed mainly on the legs here, but also when we look above, we see some areas of hyperpigmentation further up on the legs.
also, given that psoriasis can involve other areas.
One of the areas we want to examine is the scalp. In addition, we want to examine the ear, including the conchal bowl and the external auditory meatus, as well as the retroauricular area. Other areas we want to examine include the medial and lateral canthus, the alar groove, the alar rim, and under the chin, the anterior neck. We also want to make sure we examine intradigitally. Always announce what body part you will be examining next and ask permission before doing so. I hope you enjoyed our discussion about an approach to the dermatologic examination, and please visit the Stanford 25 website for more info.
The preceding program is copyrighted by the Board.
Skin lesions refer to any skin area. Diagnosis of skin lesions begins with a physical examination, and medical history in some skin lesions may require further diagnostic tests, such as blood tests, imaging, or biopsy. Specific treatment depends on the type of lesion. When examining the skin, a dermatologist evaluates the morphology of distribution, the location of skin formations, their number, size, and color, the location of the lesion, their symmetry and shape. The dermatologist will carefully feel individual lesions, noting surface and deep characteristics. Which layers of the skin are involved? If they are scaly, does the surface flake off easily? If crusted, what is underneath? Skin lesions may be flat, elevated above the plane of the skin, or depressed below the plane of the skin. They may be skin-colored or red, pink, violaceous, brown, black, gray, blue, orange, or yellow. Skin lesions can be hereditary, for example, moles or birthmarks, or are acquired as a result of a variety of conditions. One of the most common causes of skin lesions are infections. Viruses like herpes simplex, bacteria such as Staphylococcus or Streptococcus species, and fungi like Candida albicans. Other causes of skin lesions include allergic reactions, side effects of certain medications like corticosteroids or chemotherapy, contact with irritant substances, unprotected sun exposure, insect bites, poor circulation, vitamin deficiencies, systemic diseases like autoimmune diseases, some infectious diseases, liver and kidney disease, and cancer. There are primary and secondary morphological lesions. Primary morphological lesions are immediate, first results of pathologic processes in the skin. Secondary morphological lesions are formed from the primary due to their spontaneous evolution or reverse development. Primary morphological elements are subdivided into cavitary and non-cavitary. To the cavity, primary morphological elements include macule, papule, plaque, nodule, tubercle, tuberculum. To the non-cavity, primary morphological elements include vesicle, bulla, and pustule. Now we will discuss all of these, one by one in detail. Macula. Macule is a circumscribed area of change in skin color without elevation or depression. It is thus not palpable. Macules can be well defined and ill-defined. Macules may be of any size or color. Inflammatory spots, maculae always disappear on pressure, and non-inflammatory nature remains. On resolution, spots disappear completely. They are subdivided into 1. Vascular. Inflammatory, roseola erythema. Non-inflammatory, emotional, congestive telangiectasis, birthmark, nevus. Next slide. 2. Hemorrhagic, petechial, purpura, ecchymosis. 3. Pigmented. Depigmentation, general, albinism. Local vitiligo, leukoderma. Next slide. Hyperpigmentation. General, melanoderma. Local, pigmented birthmarks. 4. Artificial, fungus origin, tattoo, medicinal spots, louse bite. Next slide. Next slide. Papule. A papule is an infiltrative, non-cavitary superficial, elevated, solid lesion, generally considered less than 1.0 centimeters in diameter. A papule is palpable. It may be well-defined or ill-defined. Papules may be an inflammatory character, infiltrate resulting from dilatation of vessels and edema. Non-inflammatory, resulting from overgrowth of the epidermis, warts, etc. Accumulation of pathologic products within the dermis, xanthoma, and overgrowth of dermal tissue, papilloma. Next slide. A confluence of papules leads to the development of larger, usually flat-topped, circumscribed, plateau-like elevations known as plaques. Placket is usually well-defined. Frequently, it is formed by a confluence of papules, as in psoriasis. Next slide. Next slide. Notice is a non-cavitary formation within the dermis and hypodermis, elevated or non-elevated above the level of the skin. A nodule is a palpable, solid, round, that is larger than a papule, 0.1 centimeters. Nodules result from inflammatory infiltrates, neoplasms, or metabolic deposits in the dermis or subcutaneous tissue. Its consistency depends on the character of the inflammatory process. In the case of acute inflammation, the consistency is soft or pasty. Outlines are poorly defined. A node is of red color, its epithelialization without scar formation. In chronic inflammation, tuberculosis, syphilis, the nodes are of dense consistency, sharply bound from intact skin, and show the tendency to disintegration, their epithelialization with the formation of ulcers and scars. Next slide. Nodules may be well-defined, superficial, or ill-defined, deep, if localized in the subcutaneous tissue. They can often be better felt than seen. Nodules can be hard or soft upon palpation. They may be smooth or may have a warty surface or crater-like central depression. Next slide. Next slide. Tuberculum is a non-cavitary element, elevated and sharply bound from the intact surrounding skin, appearing after the development of inflammatory infiltrate in the dermis. The consistency of tubercles is commonly soft, but it may be also pasty or dense. A tubercle passes the stage of ulcer formation, which heals with scar formation. In some cases, an infiltrate of a tubercle may resolve without forming an ulcer. Only cicatricial atrophy of the skin remains at the site of a tubercle. Development of tubercles is typical for tuberculous lupus, tertiary syphilis, cutaneous leishmaniasis, and leprosy. Next slide. Vesicula is a primary cavity formation that contains a serous or serous, hemorrhagic fluid and rises above the skin level, less than 1.0 centimeters in diameter. Vesicula has a wall, a cavity, and a bottom. Vesicles are formed when the epidermis separates, intraepidermal cavity, or when the epidermis exfoliates from the dermis, subepidermal cavity. The direct cause of the formation of intraepidermal cavities is intercellular edema or spongiosis. Vesicles can either dry with the formation of a crust, or vesicle open with the formation of a superficial epithelial defect, erosion, which heals without a trace. Next slide. Next slide. Blister, bulla is a circumscribed fluid-filled lesion, greater than 1.0 centimeters in diameter that is usually elevated above the surrounding skin. Is a large cavitary formation with serous or hemorrhagic contents. Blisters may locate both within the epidermis and intraepidermal in the prickle cell layer and beneath the epidermis, subepidermal. A blister can be opened with the formation of erosion, and then it gradually gets dry with the formation of a crust. A blister is a primary formation in pemphigus vulgaris, pemphigoid, During's disease, erythema multiforme, and toxicodermia. Next slide. Next slide. Pustula is the primary band morphological element, containing purulent or purulent hemorrhagic exudate. Purulent exudate can be white, yellow, or yellow-green in color. Pustule develops around the hair follicles, more often staphylococcal, or on smooth skin, more often streptococcal. The size and shape of the pustules are different. The pustule, confined to the hair follicle, is called folliculitis. A superficial pustule, the contents of which quickly shrink into a crust, is called a flictina, for example, with impetigo. Superficial pustules after healing lead to or hyperpigmentation and deep scars. Next slide. Whelan evanescent, round or irregular, often flat-topped elevation of skin with a pale red color arising from edema in the superficial dermis. May vary from 2-3 mm to 10 or more cm in diameter. It is characterized by a sudden manifestation and a sudden disappearance without a trace, and is accompanied by itching and burning. The color of the element is pale pink. They appear in urticarial. Next slide. Secondary lesions are the result of the evolution of primary morphological elements. Next slide. Scarred is the replacement of normal skin by fibrous tissue in the process of healing of damaged skin. Scars are of two types, hypertrophic and atrophic. For example, acne, burns, herpes zoster, keloid. Keloid area of overgrowth of fibrous tissue that usually develops after healing of skin injury or after a severe form of acne. Atrophy. This refers to the decrease of some or all layers of the skin. Epidermal atrophy is manifested by a thinning of the epidermis and dermal and subcutaneous tissue. There is a loss of skin texture and cigarette paper-like wrinkling. In dermal atrophy, there is a loss of connective tissue of the dermis and depression of the lesion. For example, leprosy, atrophoderma, lipotrophy. It is the reduction in size and the number of skin cells. It may be limited to the epidermis, dermis, or subcutaneous tissue. Next slide. Erosion is a defect only of the epidermis. Erosions do not penetrate below the dermo-epidermal junction, and therefore heal without scarring. temporary hyperdepigmentation may be observed. Erosions are always the result of intraepidermal or subepidermal cleavage, and thus of vesicles or bullae. For example, tinea pedis, candidiasis, eczema, herpes simplex. Next slide. Ulcer, a deep defect in the skin in which the epidermis and papillary dermis are lost. Deep ulcers seize all layers of the dermis and subcutaneous tissue. Ulcers can occur when an opening of tubercles, nodes, or deep pustules. They differ from the wound, which is a defect in healthy tissues. Ulcers have a bottom and edges, which can be soft, for example, with tuberculosis, or dense, for example, with skin cancer. Ulcers always heal or are slow to heal with scar formation. Next slide. Fissure linear defects, breaks, arising from loss of elasticity and infiltration of individual skin areas. Cracks are often accompanied by soreness. There are superficial and deep. Surface cracks develop within the epidermis and often occur with xerosis of the skin. They quickly epithelialize and regress without a trace. Deep cracks are localized within the epidermis and dermis, often bleed with the formation of hemorrhagic crusts, are painful, and regress with scarring, for example, Robinson-Fournier scars and syphilis. Next slide. Crusts develop when serum, blood, or purulent exudate dries on the skin surface. Crusts may be thin, delicate, and thick. Crusts are yellow when formed from dried serum, green or yellow-green when formed from purulent exudate, or brown, dark red, or black when formed from blood. If it is accompanied by necrosis of the deeper tissues, the dermis, the condition is known as ecthyma. Next slide. Excoriation, a scratch, is a result of mechanical damage to the skin, scratches and skin traumas. Next slide. Scale, a thin flake of epithelium, mostly composed of corneocytes, that is separated from the underlying intact skin proper. Scales are due to hyperkeratosis, accumulation of stratum corneum due to increased proliferation or delayed discrimination. We can differentiate different kinds of diseases by just looking at the scales and their shapes. For example, psoriasis has silvery scales. Pityriasis versicolor, powdery scales. Next slide. Lichenification. In the case of lichenification, the skin becomes thickened, and the skin looks rough. The skin surface is dry, and cracks and scales appear on the surface. The process usually with itching. Next slide. Vegetation is the overgrowth of the papillary layer of the dermis, papillomatosis, and a prickle cell layer of the epidermis, acanthosis. Vegetation, its surface is either dry or erosive with the presence of exudate. Let's look together at a short video about immunology in the skin.